Welcome to the Surgical Edge podcast for surgical insights, reviews, discussions, and to stay updated. Let's dive in.
Welcome to the Deep Dive, your shortcut to being well-informed. Today, we're pulling back the curtain on a really intense world, what it's really like to be an on-call surgical registrar in the NHS, the UK's National Health Service. Our mission for this deep dive is to get the most critical insights from this guide, On-Call Excellence for General Surgery Registrars in NHS. One, reveal what it actually takes to be that central figure, the one making life-saving calls during those high-pressure, out-of-hours shifts.
Yeah, and what strikes you straight away from this guide is it's not just about being good with a scalpel, is it? This role demands, well, a powerful mix of leadership, really rapid decision-making, and communication under, frankly, immense pressure. And these skills, they're relevant way beyond an operating theater. So this deep dive could be valuable for anyone, really, in any kind of high-stakes situation, leading a team, managing a crisis.
Absolutely. The responsibility is just, wow. Reviewing urgent referrals, leading whole teams, managing situations where it's life or limb on the line. So, okay, what does this actually look like on the ground? Imagine being that linchpin, the leader, when everyone else has gone home. The guide really sets this up, calling them the clinical leader for the shift. They're the crucial bridge, it says, between the junior doctors and the consultant.
Sort of the conductor of the orchestra when the main consultant isn't right there.
Exactly. And the list of responsibilities. It's huge. Reviewing ED referrals, that's the emergency room, managing really sick surgical patients already admitted.
The inpatients.
Leading the post-take ward round, supervising emergency procedures, deciding who needs theater urgently.
Triaging, essentially.
Right, triaging. Plus, supporting the junior staff, the SHOs, the FY1s, the first-year docs, and then constantly talking to other specialties. Radiology, anesthetics, ICU. It's like a 360-degree job.
And that leads straight into, probably the most critical skill. Triage. The guide really hammers home this surgeon's mindset. Prioritize life or limb-threatening cases first. Simple as that. So think things like a perforation, a hole in the bowel, maybe sepsis, acute bleeding. Those jump the queue.
Okay.
And patients showing signs of peritonitis, that inflammation inside the abdomen, or sepsis, or an obstruction like a blocked bowel, they're right up there too. The more stable reviews, the routine stuff, that can often wait or be handled by the junior team members.
So it's about quickly getting the big picture.
Absolutely. Maintaining a clear overview. The guide even suggests using an on-call board. Could be digital, could be a whiteboard, just to track everything.
Like a command center dashboard.
Exactly. Tracking the ED referrals, what's happening in theater, who's sick on the wards, who you've asked to do what. You need eyes everywhere.
So that sounds incredibly demanding, keeping all those plates spinning.
Yeah.
And beyond just managing the information, there's leading the team.
Yeah.
How does that work?
Well, it starts right at the beginning of the shift, setting clear expectations.
Yeah.
Meeting with the SHO and the FY1 who are on with you. You allocate roles, you agree on how and when they should escalate things to you. And critically, the guide says, be approachable. You want the juniors to call you, even if they think it's small.
Right. No hesitation.
Exactly. Which flows into delegation. The guide uses this great phrase, delegate, but don't abdicate.
Meaning?
Trust your juniors, yes, but you still need to verify the really key findings yourself. You, the registrar, have to personally review unstable patients. And you should be there for the tricky procedures, maybe a difficult fivine, putting down an NG tube, or examining someone with sudden severe belly pain and acute abdomen. You need to know when to step in.
So empowering the team, but keeping that crucial oversight, that's a leadership lesson for anyone, isn't it? But what about when you have to make the call, that clinical judgment under fire?
Yeah, the core of it. The guide stresses getting a focused history, listening for those red flags.
Like what?
Things like pain that seems way worse than you'd expect, constant vomiting, any sign of peritonitis, features of sepsis like fever or confusion. Those are the immediate alarms.
Got it.
And here's a huge point. Always examine yourself when the case is unclear or serious. You can't just rely on blood tests or scans to make the big calls, or, importantly, to delay making them. Your hands-on exam is vital.
Okay, so examination first. But what about imaging scans?
Crucial, but use smartly. Know when to ask for a scan and how. Like a CT scan of the abdomen with contrast if you suspect a blockage or perforation, and talk to the radiologist. Give them clear clinical context. Tell them what question you're trying to answer with the scan.
Just order it blind.
Exactly. And then you need to look at the scan yourself. Don't just rely on the report. And if it's complex or subtle, get your senior involved. You're the one putting all the pieces together.
Right. So let's talk emergencies. Acute abdomen or sepsis, what's the playbook?
Immediate actions. Get IV access alignin. Draw bloods, blood cultures. Check a lactate level that tells you how sick they are. Start fluids, resuscitation, and start broad-spectrum antibiotics quickly, following local guidelines. But the big message is, request senior review. Early delays worsen outcomes. Don't wait.
Don't try to be a hero.
Precisely. And use the scoring systems, things like QSOFA, P, POSSUM, and NELA. They're quick checklists to assess how sick someone is, their risk, and it gives everyone a common language for urgency.
Okay, and what about the really scary stuff? Surgical bleeding or perforation? The stakes seem even higher there.
They are, and the guide is clear. Early escalation to the consultant is paramount. Don't hang about.
Just call them.
Call them straight away. While you're doing that, you're liaising with theaters, the operating room staff, with anesthetics, with ICU, getting everyone ready. And for really unstable patients, the guide mentions considering damage control principles.
You mentioned the pit stop idea.
Yeah, it's fascinating, isn't it? Instead of one massive operation that the patient might not survive, you do the bare minimum to stop the bleeding or contamination, get them stable, maybe go to ICU.
And then come back later for the definitive fix.
Exactly. It's a tough call, but often life-saving. The speed and coordination needed there are incredible.
Wow. And holding all this together is communication.
Absolutely fundamental, especially with your senior support, the consultant. They expect early calls if things are serious, or if you're just not sure, don't be afraid to bother them.
How should you approach that call?
Be direct. The guide suggests something like, I'm worried about this patient because... Get straight to the point.
Right.
And keep them updated. If the situation changes, if theater priority needs adjusting, let them know. It's about shared decision-making.
And communicating with other departments. Radiology, ICU again.
Needs a good touch. Be assertive but collaborative, the guide says. You need things urgently, but you need their cooperation. Give them clear, concise summaries, like the example. 78-year-old male, suspected ischemic bowel, tachycardic, lactate 5.3, awaiting CT. Straightforward.
Gets the point across quickly.
Yeah. And, having a good relationship, the good rapport with radiology and ICU, it really helps when things get busy. Building those bridges pays off.
Okay, communication sorted. What about the paperwork side? Documentation.
Absolutely critical. You must record your reviews, especially for the sickest or highest risk patients. Note the time you saw them, the clinical picture, your assessment, the diagnosis you're working with, the plan, and who you've escalated to.
Cover your bases.
And protect the patient. Also document things like NBM status, nil by mouth, whether consent's been done, discussions about theater, and really importantly, DNR status if it's relevant. As the guide says, good documentation protects patients and you. It's your safety net.
Right. So beyond individual patients, there's managing the flow, especially the emergency theater list. The registrar owns this.
They really do. You need to know exactly what cases are on the list, in what order they're planned. You need to be aware of any limitations, maybe anesthetic issues, ICU bed availability, equipment problems, and coordinate constantly with the theater staff.
And prepping the patients.
Yes, preoperatively reviewing everyone going to theater yourself.
Yeah.
Check consent is right, the site marking is done, documentation is complete. And again, that theme, escalate early and clearly if there are delays expected for someone who really needs to get to theater fast. Logistics leadership.
And when the shift finally ends, handover must be watertight.
Absolutely crucial. Use a structured approach like SBR situation, background assessment recommendation, or a specific surgical handover template. You need to clearly outline the key patients you saw overnight, anyone waiting for scans or senior review.
The unwell and patient.
Any pending theater cases, any decisions still needing to be made, and any outstanding jobs for the incoming team. And for the night handover specifically, make sure patients are stable or properly escalated and spell out the plans and, importantly, any ceilings of care.
Like decisions about resuscitation limits.
Exactly.
Yeah.
And keep any handover systems, digital or paper, updated in real time, no guesswork allowed.
Just listening to all this, the constant vigilance, looking for red flags, coordinating everything, it sounds utterly exhausting.
It is, which is why the human element the guide touches on is so important.
Like taking breaks.
Yes.
Yeah.
Actually taking breaks, even just 10 minutes to grab a coffee, some water, just breathe, and making sure your juniors do too. It's vital for performance and avoiding burnout.
And looking after the team emotionally too.
Definitely. Leadership through empathy, the guide calls it. Check in on your team, especially the FY1s. It might be their first really tough on-call. Maybe do some teaching if there's a quiet moment, but always put safety and morale first. support colleagues who are struggling. Your attitude, your tone sets the culture, as the guide puts it. It's about fostering that supportive environment even under pressure.
So wrapping up the guide's view, being an on-call surgical registrar, it's incredibly tough, but also really rewarding.
A true test, isn't it? Leadership, decision-making, clinical confidence, all rolled into one.
And the core principles for succeeding.
They come through loud and clear. Prioritize safety, think clearly, communicate early, and lead by example. That's the mantra.
So the checklist for excellence boils down to triage well, lead your team. Be there for the critical patients. Communicate clearly up, down, and sideways. Document everything vital. Own that theater list. Hand over like lives depend on it because they do. And stay calm, support your team, look after yourself.
That's the essence of it.
So thinking about this for everyone listening, what does this all mean for you? It's clearly more than just surgery, isn't it? It feels like a masterclass in high-stakes leadership, how to assess situations rapidly and manage a team with compassion under fire. Makes you wonder, what unexpected situation in your life, maybe your work, could benefit from applying this on-call mindset, that focus on clarity, decisive action, and team support when things get tough?
Yeah, and if we zoom out even further, connect it to the bigger picture, it really prompts a question, doesn't it? In this world we live in, with constant information, constant demands, how do you effectively prioritize? How do you delegate? How do you maintain that clarity and calm when the pressure cooker environment is on, especially maybe when the well-being of others hinges on the decisions you make?
Thank you for listening to the Surgical Edge podcast. Don't forget to like, share, and subscribe. Help us grow and deliver even more relevant surgical content by pressing the support button. Your contribution truly makes a difference. And don't forget to share with us your advice, feedback, and the topics you would like us to include.